So let us come to the ECG more common conditions. Let us initially take this tetralogy of Fallot atrial septal defect. Say a 2-month-old child, classical signs of tetralogy of Fallot. If somebody asks you what is the ECG finding in tetralogy of Fallot, what you should say, it is right axis deviation, right ventricular hypertrophy, and counterclockwise loop. Sorry, clockwise loop. That's all. Okay. So what is the ECG finding of tetralogy of Fallot? Right axis deviation, right ventricular hypertrophy, and clockwise loop. Now, there is no ECG finding that is very specific for a classical TOF. This we have to remember. Because in the first 6 months, there will be anyway right ventricular hypertrophy and right axis deviation for all children, isn't it? And there will also be a clockwise loop. So this finding of normal finding, which is a right axis deviation and right ventricular hypertrophy, is also the finding in TOF, and hence there is no typical ECG finding for TOF. In addition, most of the serious heart diseases, they also have right ventricular hypertrophy and right axis deviation, say transmission of great arteries and say truncus arteriosus. Not only that, all TOF-like situations, they also have right axis deviation and right ventricular hypertrophy. Like DVRV VSD-PS, corrected TGA-PS, single ventricle PS, TG-VSD-PS, ECD-PS, all will have this, except this ECD with PS, all will have right axis deviation and right ventricular hypertrophy. So as a corollary, in a case with suspected tetralogy of Fallot, if there is no counterclockwise loop, no RVH or no right axis deviation, that means we are dealing with a more complex congenital heart disease than a simple tetralogy of Fallot. Let us go further. This is a classical ECG of tetralogy of Fallot. See, there is right axis deviation. There are QFs in 2, 3 AVF, clockwise loop. There is a sudden transition from V1 to V2. Somebody might suggest that this is a very classical finding of TOF, which is not, because see the next ECG, this is also a TOF patient. Is there a sudden transition? So the sudden transition of QRS or the RVF from V1 to V2 is neither specific for TOF nor sensitive for TOF. If the finding is there, it's well and good. If the finding is not there, but still it's okay. But that you should remember that commonly in the exam, this is what the examiner is asking, and this is what you should answer. But practically, this is not very true. This finding is seen, but this is neither specific nor sensitive for tetralogy of Fallot. Is there any other utility of ECG in tetralogy of Fallot? See this case, a 1-year-old child with tetralogy of Fallot, severe cyanosis. He has all the findings, right axis deviation, clockwise loop, 2, 3 AVF showing key waves, and RV dominance is there. But what about V5, V6 R wave? They are very, very small. What does this tells to us? You know, in tetralogy of Fallot, the severity depends on the amount of pulmonary blood flow. If more the pulmonary blood flow, less severe is the situation. Less is the pulmonary blood flow, more severe is the situation. If the pulmonary blood flow is good, then all the pulmonary blood flow will come to the LA and LV. So if we have a good LV forces in V5, V6, that might indicate good pulmonary blood flow and hence a relatively milder form of tetralogy of Fallot. Whereas if you have very poor LV forces, and as in this condition, if you have very poor LV forces, that might mean the pulmonary blood flow is very much restricted, and hence this child is a very sick case of tetralogy of Fallot. So that is the utility of additional utility of ECG in tetralogy of Fallot. So when a patient has clinically TOF, and if there is right axis deviation, right ventricular hypertrophy, and V1 V2 sudden transition, most probably we are dealing with a classical simple TOF. If there is left axis deviation and counterclockwise loop, where clinically you are diagnosed TOF, you are dealing with endocardial cushion defect or tricuspid atresia as the underlying lesion. If there are AV blocks, think about endocardial cushion defect or corrected transmission of great artery as the underlying lesion. And if there is extreme axis, biventricular features or LV dominance, then that's a complex pathology. Don't try to guess the underlying lesion based on the ECG. So this should be the interpretation. What about double outlet right ventricle? So we should remember that double outlet right ventricle is a finding than a diagnosis, because a DOR can be a simple VSD, it can be TOF, it can be TGA, or it can be a single ventricle. That's what we call as complex DOR. So when you write in your diagnosis DORV, if you simply write one line as after the echo as DORV, it means nothing. So DORV means TOF-like DORV or TGA-like DORV or complex DORV, or DORV in bracket you should write simple VSD-like DORV. So all DORVs come into one of the four. Because DORV has so many expressions, we cannot have a single finding as finding of DORV. So there is no specific finding of DORV in ECG. But I do see examiners asking for what is the ECG finding of DORV. They do say something. But in my understanding, there cannot be a single ECG finding for DORV. What about single ventricle? Most of the time, there are two ventricles. There could be a large functional right ventricle, like in the case of mitral atresia, or there could be a large functional left ventricle, like in the case of tricuspid atresia. The underlying pathology could be double indent left ventricle, endocardial cushion defect, corrected transposition, etc. And again, there is no specific finding for single ventricle in ECG. So somebody may say monophasic R or monophasic S in V1 to V6. Yes, that may suggest. But anyway, we cannot have one single ECG finding for single ventricle. So just see, take this child, this 4-day-old child with cyanosis and shock. There is no the axis in the no man's land. It's extreme right axis. Why do you say it's extreme right axis? See that there's a tall QRS in lead 3. So it is extreme right axis. Extreme right axis and extreme RV dominance. This child actually had hypoplastic left heart syndrome. I won't say that this is classical of hypoplastic left heart syndrome, but you can imagine this will be the finding in a case with hypoplastic left heart syndrome, because left heart is basically it's not developed. Let us come to the simple ostium secundum ASD. What are the findings in ostium secundum ASD? There is normal QRS axis. There will be clockwise loop and the so-called RS pattern in V1. Very classical, everybody aware of that. This is the classical finding of ostium secundum ASD. 4-year-old child, clinically ASD, more than 2:1 shunt. You are diagnosed clinically ASD. He has been referred to you for device closure. Okay. And you have taken the ECG. This is the ECG. What is abnormal of this ECG as compared to the previous ECG? Here there is a typical RS pattern is there. But what happens here? There is a left axis deviation. Lead 1 is positive, AVF is negative. And you have Q waves in 1 and AVL. When you have Q waves in 1 and AVL left axis deviation, what did it say? It suggests you have a form of endocardial cushion defect. So clinically we have diagnosed ASD, and ECG suggests you have endocardial cushion defect. That means it suggests you have ostium primum ASD. So after ECG itself, you will be able to tell the patient that most probably I will not be able to close this by device. I should be sending for surgery because I am expecting a ostium primum defect, which is not going to be amenable for device closure. Okay, this is another example of ostium primum ASD. Again, left axis deviation and RS pattern. What about this ECG? A 3-year-old child with signs of ASD. Here you see some kind of flattening of P wave or very small positive P wave in lead 1. A negative P wave in AVF. So here there is a change in the axis of the P wave. Which ASD will have a different axis of P wave? You can imagine that it's a sinus venous ASD. Because sinus node is there, sometimes sinus node dysfunction is associated with sinus venous ASD. They cannot this measure of ECG. But even in sinus venous ASD, P axis is normal. If you find an abnormal P axis, that might tell you that it could be a sinus venous ASD. Now, this is a 1-year-old child with ejection murmur. Echo shows 12 mm ASD. 12 mm ASD is a very large ASD for a 1-year-old child. You can see that there is right axis deviation and there is RV hypertrophy features. Rather, non-regression of the RV is still persisting. This child, we need to subject the child for surgery very early. This is not the usual RS pattern you will see. Here you see actually a RV strain pattern. So this is a small 5% children, 5% of the children who will need surgery for ASD before 1 year. But on the other hand, you take this 32-year-old gentleman who is a known case of ASD. He has right axis deviation. He has tall R waves. He has a QR pattern and RV strain pattern. So if this kind of ECG is there, most probably he is going to be inoperable. Even if he has clinically normal, clinically there is no desaturation. Even if your echo is showing ASD shunting only left to right, this kind of ECG will tell us, or most probably tells us, that he is probably has gone towards inoperability. So how do we read ECG in ASD? The QRS is normal or rightward in V1. There is RS in V1. If P axis is leftward, suspect sinus venous ASD. But remember that most of the sinus venous defects have normal P axis. If there is left axis deviation of the QRS, again suspect ostium primum ASD. As the PAS progresses, the RS changes gradually to monophasic R and then to QR pattern. Like here, it's almost a QR pattern. If you have QR pattern, that means the RV pressure is much higher than the LV pressure. Okay, so this is how we use this is the utility of ECG in ASD. This is a second post-operative day in a child operated for ASD. You can see a ST elevation in multiple, almost all leads. You have ST elevation in all leads with concavity upwards and PR depression in all the leads. See the PR depression? So this is a very classical feature of pericarditis, which we see very common in the post-operative period. This is nothing to worry. As the inflamed operation-related inflammation goes up, this will go away. So it's a 6-month-old child, more than 2:1 post-tricuspid shunt. I have simply given it as post-tricuspid shunt. So very classical ECG of biventricular hypertrophy, what we call as a KW phenomena. This is a feature of a large VST. Now, another example of a large VST, which we have commonly seen, so there is nothing to discuss. See here, come back again here. There is right axis deviation. See the QVs in 2, 3 AVF. They all will have the usual clockwise loop. Okay. Now, the same biventricular hypertrophy features, but see there is a QV in 1 and AVF, counterclockwise loop. So, as I told earlier, either we are dealing with an inlet VST here, or whatever may be the VST that's going to have a significant inlet extension. Okay. So, that's the interpretation of this ECG. Okay. Now, this is a 10-year-old child, asymptomatic, echo shows large VST. Now here, it's a right axis deviation. RV strain. There is no LV forces. So we know that the child is again, as I gave an example of ASD, this is a child which has gone towards asymmetrization. These are the features where ECG suggests that inoperability is probably there. So what about ECG in post-tricuspid shunts? The QRS axis is rightward or normal. If it is towards left, think about endocardial cushion defect or inlet extension of VST. In older children, if there is right axis deviation with RV strain pattern, it may suggest development of pulmonary vascular disease. So we have to be very careful. LV forces correlate very well with the degree of pulmonary blood flow. Hence, those with increased pulmonary vascular disease or frank ischemic syndrome will not have a tall LV. It will become normal LV. Okay, the tall LV becoming a QRS complexes, becoming normal QRS complexes means that the pulmonary vascular disease has set in and patient is going towards ischemic syndrome. This is how we can utilize the ECG in the post-tricuspid shunts. So this boy is an asymptomatic boy with incidental murmur. So what do we see here? Tall or in, say this 10-year-old boy, tall or in V1. So this child had ejection murmur, this child had pulmonary stenosis. So in pulmonary stenosis, what do we expect is the right ventricular hypertrophy. So what about this one? This is another patient, 12-year-old boy, known heart disease since early childhood, severe effort intolerance. Now what you see here, right axis deviation, some broadening of QRS and QR pattern in V1. As I said, if you have QR pattern in V1, that means suggest systemic right ventricular pressures. Indeed, this child had a supraventricular right ventricular pressure. This child also had severe pulmonic stenosis. So ECG in pulmonic stenosis, the height of R in V1 and V3R correlates with the severity of the pulmonary stenosis. There will be right ventricular hypertrophy and right axis deviation. The QRS is northwest. Just remember this. In a child whom you have diagnosed as pulmonary stenosis, the QRS is northwest. This is peculiarly seen in patients with Noonan syndrome. Okay. In aortic stenosis and coarctation of aorta in the newborn period, though it's a left-sided disease, they do not show LVH. Rather, they will show only RVH. Because RV was the dominant ventricle in the newborn. In spite of having severe AS and severe coarctation of aorta, newborns will not show LVH in the ECG. In older children, adults, the degree of LVH correlates with the severity of these two lesions, AS or coarctation of aorta. So this is a 12-year-old child, mild cyanosis and dyspnea and exertion. This is very classical of what we call as Epstein's anomaly. Okay, you have very broad, bizarre QRS, RBB like or whatever you call. Again, you have a very bizarre QRS. This is a suggestion of Epstein's anomaly. Again, I'm giving multiple examples of Epstein's anomaly. You can see the tall PVs. Most of the time, they also have this tall PVs because of the very large enlargement of the right atrium. So I'm coming to the last part. I just quickly finished. Hope you got the idea of how to exactly utilize the ECG in patients with congenital heart disease. Role of ECG in cardiomyopathy. It's a 3-month-old child referred as dilated cardiomyopathy. But if you see here, there are tall QVs in 1 and AVL. There is ST depression T inverse in the lateral leads. If this ECG is given in an adult, we generally diagnose this as either severe left ventricular hypertrophy or lateral wall ischemia. Okay, when a 3-month-old child, which cannot have this ECG, isn't it? A 3-month-old child should have a right axis deviation, should have a RV dominance, but he has feature suggestive of heart failure, echo showing LV dysfunction, patient is referred as dilated cardiomyopathy. But ECG showing Q waves in 1 and AVL, features of lateral wall ischemia. It's very classical Al-Kappa. We should never ever forget about this. At times, what happens? This is a 6-year-old girl referred as moderate MR. It was only MR. There was some scarring of the papillary muscle. It was not suggestive of rheumatic heart disease. This is the ECG. It's the same finding. Same Q in 1 and AVL, kind of left axis deviation, and a T inversion in the lateral leads. This child also had anomalous origin of left coronary artery from the pulmonary artery, what we call as Al-Kappa. So in the newborn period, any child with LV dysfunction, we have to rule out this Al-Kappa. In an older child, if there is isolated mitral regurgitation, before diagnosing rheumatic heart disease, of course, other telltale evidence of rheumatic wall involvement, it's okay. Otherwise, one should have this possibility in the mind. So this is a 4-year-old boy with dilated cardiomyopathy. What you can see, there's a tachycardia and there's an inverted period prior to that. It's a long RP tachycardia. So how to deal with the long RP tachycardia? Subsequently, Dr. Jonathan is going to talk. But anyway, once you diagnose that there is a unusual tachycardia going on, once you treat the tachycardia, the cardiomyopathy will improve and they become near normal. So this is the utility. See, this is the same child's ECG after ablating the tachycardia. So in a child with dilated cardiomyopathy, we have treatable cardiomyopathy. These two important things. One is Al-Kappa, second is tachycardiomyopathy. Both are very well diagnosed by ECG. Please remember that. So if you are sending away a patient with dilated cardiomyopathy without taking ECG, it's a very grave mistake. So this is a 3-month-old child referred as hypertrophic cardiomyopathy. Like this kind of extremely tall QRS complexes are seen in Pompe's disease. This is extremely rare. Pompe's disease is very rare. After coming to Madurai, I have not seen one. I have seen at least 2 cases when I was at Amrita. So this is a classical example of Pompe's disease. So ECG in cardiomyopathies, Al-Kappa has to be ruled out in all cases of DCM and isolated mitral regurgitation. Even mild innocent tachycardia can cause cardiomyopathy. Young infants with hypertrophic cardiomyopathy with LV dysfunction, please rule out Pompe's disease. Okay, so arrhythmias again is going to come back subsequently. So summarize my talk. ECG is very useful in identifying situs and cardiac position. It is diagnostic in certain conditions like tricuspid atresia, endocardial cushion defect. It aids in assessing the volume or pressure overload in shunts and other valvular lesions. It is useful in many non-cardiac conditions like hyperkalemia, hypocalcemia, which I have not discussed because it's a general topic, which anyway you all will be knowing. Al-Kappa and tachycardiomyopathy should be ruled out in any case of dilated cardiomyopathy. Thank you for the patient listening. Thank you.